Hi everyone, welcome to the MMOA podcast. Today we're going to be reviewing and talking about a study on deep brain stimulation in Parkinson's disease. So we're pretty much going to look at what happens after this surgery is done. Because even when the tremors and rigidity should improve, patients are often left with balance issues, gait problems, and a continued fall risk. So today we're breaking down a study that looks at something that doesn't have a lot of research to it, but I think it's super important to know because we do have patients with deep brain stimulation in Parkinson's. So we're going to be looking at, does physical therapy actually help after having a deep brain stimulator implanted? My name is Kay Mayordomo, and I am a home health physical therapist and also a group fitness coach for older adults. I recently had a home health patient with Parkinson's who recently had a deep brain stimulator implanted, and it was something I wasn't really familiar with, so I decided to dive deeper into the research and share what I found. I'm definitely more well-versed in the outpatient ortho PT world, but in home health, there are definitely a wider variety of patients we need to help, so I figured why not learn about this population of patients to be able to help them better and share what I found with all of you guys. So the study we're going to be looking at was published in the Journal of Neurologic Physical Therapy in October 2025, and it was called Physical Therapy and Deep Brain Stimulation in Parkinson's Disease: Safety, Feasibility, and Preliminary Efficacy. So first off, we're going to be going over what is deep brain stimulation. So deep brain stimulation is a surgical intervention where electrodes are implanted into the brain, commonly the subthalamic nucleus. We're going to be calling it STN the rest of this podcast, and we're going to be referring to deep brain stimulation as DBS. So I might be saying STN DBS just to make it a little shorter. So usually electrodes are implanted into the brain, commonly the subthalamic nucleus, in patients with more advanced Parkinson's disease. And this device delivers an electrical stimulation to regulate abnormal motor signals. So this is usually shown to be helpful for tremors, rigidity, bradykinesia, but there is a but. It doesn't consistently improve balance and gait. And in some cases, it can possibly worsen balance and gait. So we're gonna dive into the study. So what was the study? The main question that this study looked at was, can PT improve balance and gait after having surgery for DBS? So the study was a randomized pilot study, and they had 29 participants total. So the PT group had 15, and the control group, which they called usual care, had 14. All of the participants had Parkinson's or have Parkinson's disease and underwent a procedure to have the STN DBS. And they were all at least 1 year post-op of this implantation, and they were between Hone and Yar stages 2 to 4 when they were on their medication and on stimulation. The participants that were excluded were the ones that had atypical Parkinsonism and evidence of a significant cognitive impairment. They used the mini mental status exam to pretty much figure this out, and if they had the inability to walk 10 meters with or without an assistive device. So participants who scored low on the mini mental status exam and weren't able to walk 10 meters were excluded from this study. And that was for the people in the off state and on state. And I'll talk more about what that means in a sec. So the intervention was, so the participants, we had the PT group, right? The PT group consisted of balance and gait training. So it was an 8-week physical therapy program. They focus on quiet stance, anticipatory and reactive postural control, and dynamic postural control. The gait interventions consisted of treadmill walking, and they also did overground dual task walking with the hopes to improve spatiotemporal gait variables. And the PT group was also given a home exercise program of lower extremity functional movements, sit to stands, heel raises, hip flexion, standing half squats for twice a week for 8 weeks. So they compared this to a usual care group, so no structured physical therapy, and these participants went about their daily lives. Both groups, though, received a current standard of care, so they pretty much had optimization of the STN-DBS parameters and also anti-Parkinson's disease medications as prescribed. The main outcome measures used were the BEST test, so they used a total score on the BEST test, and this is known as a comprehensive and reliable assessment of postural stability in people with Parkinson's. And for gait, they looked at average gait velocity, they looked at stride length, and they looked at stride to stride variability. And what was cool about this study is they tested all of the PT participants in an on medication, on stimulation piece, and they also tested them in off medication, off stimulation. So off medication was defined as at least 12 hours since the last dopaminergic medication. Off stimulation was defined as 45 minutes after the stimulators were turned off. On medication was defined as 1 to 1.5 hours after dopaminergic medication, and on stimulation was defined as the normal clinically optimized STN-DBS settings. The conditions, so the on and off were tested on separate days and had at least one day but not more than 1 week between assessments. So now, what did this study find? So first off, they found that PT was safe. So there were no serious adverse events during treatment. And I think this has to be said, right? Because if people are undergoing a procedure and they're like, well, can I even do PT after this? Like, it's supposed to change how I'm moving, right? So should I be doing PT? And what you can tell people is, yes, these people were safe. The PT group didn't have any adverse events. And what they also found was PT had a good attendance rate. So they had 93% of patients actually show up and complete the 8 weeks of PT, which is cool. And the balance, what they found was there was improvements in balance, but not necessarily that clinically meaningful. And this was in the on medication, on stimulation state. They didn't find any significant improvement in any groups for gait, and no meaningful changes in the off condition. So what we can note, though, is with this study, they focused on balance and gait, and what they didn't focus on, which the author mentioned, is that there wasn't a big emphasis on aerobic and resistance exercise at a high intensity within their PT interventions. So there was a study that they mentioned that had individuals after a 6-week intervention of PT that included aerobic exercise, strength training, and flexibility, and they had greater improvements in their balance compared to the findings of the study that we're covering right now. So, I mean, like with every study, there were limitations to this study. So it was a small sample size. I mean, it was a pilot study, right? Short duration, 8 weeks. And the author noted this, but maybe we did need to add a higher intensity of aerobic exercise, and maybe strength training also needed to be added. But this study mostly focused on balance and gait. So it is good that they kind of narrowed this down, though, because that tells us when the patient is in an on state for their medications and for the stimulation, they are seeing improvements in balance, but when they're in the off state, they're not. So maybe this tells us a little bit about timing of PT interventions that we can take advantage of, right? And so since gait didn't improve, maybe this tells us that we need a different approach, right? So maybe we need to make the dual task training potentially harder. Maybe we're using more external cueing. Maybe we're adding more intervals, so something higher intensity. But this study I thought was really cool. So even though we have these interventions like DBS, like deep brain stimulation, and it's supposed to help with Parkinson's disease, with the symptoms of Parkinson's disease, since we know that it doesn't necessarily improve balance and gait, I think it gives us more fuel to say that function still needs to be trained and PT is still necessary to help this population. So I think with some people, when they get surgery, they think, oh, I've had surgery, that means I'm good, I don't need to do PT. But what this study is telling us that, hey, maybe physical therapy is helpful and it wouldn't be harmful for you to try. So I thought it was great. I think that we need to continue to gain more research with this population. So I think what would be really cool is if there was a study that looked at including high intensity aerobic activity and strength training, and maybe more higher intensity strength training. So not just sit to stands and heel raises, but really looking at maybe like 80% of somebody's 1 rep max and just going a little bit higher of an RPE. So cool study. I'm gonna just review it real quick for you guys. So today we covered what deep brain stimulation is. So like I said earlier, it's a surgical intervention where electrodes are placed in the brain, most commonly in the subthalamic nucleus, and it's supposed to regulate abnormal motor signals. So super helpful for tremors, rigidity, and bradykinesia in our patients with more advanced PD, which is cool that they studied this because usually our patients with DBS who have more advanced Parkinson's are excluded from a lot of PD studies. So the fact that there's a study specifically on this is super cool. And the study was a randomized pilot study with 29 participants total. 15 in the PT group for 8 weeks of balance and gait training, and a home exercise program also prescribed, and a control group that went about their usual activities. So the PT group, they found, had some improvements in balance, but not in gait. And I think this is a really good starting study to help us figure out how to help these patients better. So I really hope that you guys enjoyed learning with me more about patients with DBS who have Parkinson's and what to do about it. Next time, though, I'm going to be going on the podcast to go over the case of my home health patient I'm treating with DBS. I just kind of wanted more weeks with this patient so that I could really reassess our outcome measures and see how helpful things were and whether I had to shift what we were doing. There were also some insurance limitations, so I wanted a good chunk of time to really work with him before I presented a case to you guys. But next time, that's what I'm going to be going over. So stay tuned for that one. I'm really excited to share it with you guys. And if you guys would like to learn more about PD or other special populations of older adults, please join us at an ICE Physio course in the older adult division specifically. So our next older adult live course will be this weekend, March 28th to 29th in Bismarck, North Dakota. There will be one April 11th to 12th in Virginia Beach, Florida, and April 25 to 26 in Kansas City, Missouri. Level 1 is starting back up again May 20th. But level 2, which level 1 and level 2 are both online, level 2 doesn't start again until September 16th. But if you take level 1 May 20th, then you could totally join level 2 September 16th. If you're like, oh my gosh, this content is so great, I need to learn more, then you can just join us pretty much right away. So I hope you all have a great week, and thank you for joining me on the MMOA podcast. Have a good one. Bye.